It is Pain Awareness Month here in September, and we're back with Arpan Patel MD, our Director of the Pain and Spine Center here at Edgerton Hospital and Health Services. Dr. Patel, I know you wanted to get into spine pain and things that treatments that are available that can be really effective and helpful.
Yes. Spine for us is about 80% of our patients, so either neck pain, upper back pain, or lower back pain. And I could talk a little bit about neck, but really it follows through from the top to bottom. So I'll focus on back pain right now, and we'll just talk about some of the kind of higher advanced solutions that we have for back pain, and there's a variety of different sources of pain for your back. It's an hour and a half, 2-hour topic if we go through each thing that we do, so we're just going to talk about the bigger things. The smaller procedures that we do are like epidural steroid injections, which most people have heard of other people getting steroid injections for the spine. Those are our bread and butter. We have a lot of patients that need those for treatment. The kind of next more invasive type of procedure is ablations. So people that have arthritis of the spine, that's a treatment for them. We can burn the nerves that go to individual joints in the spine and give them a year or so relief of pain from arthritis. They may have to have a repeat ablation done, but that's something we offer for arthritis of the spine. When we look at spinal stenosis being something where patients have narrowing and crowding of the central canal. So this is the disc, and this is the back of your spine. In between the areas of your vertebrae and your spinal column here is your spinal cord. When your spinal cord gets squeezed, the body doesn't like that. Your back doesn't like it, and your legs don't like that. So all these spine nerves in your back end up going in your legs. So stenosis just means narrowing of the actual diameter of the column where the spinal cord goes. Central stenosis causes patients to kind of have to bend forward while they walk. They have trouble with standing for any 5 minutes or so. They have trouble with walking 200, 300 feet before they have to sit back down. Once you sit back down, the pain goes away, then you can stand back up and walk a little further. And that's just because as your spine moves forward, it opens that space in that column. Minimally invasive treatment could be an epidural steroid injection. Steroids are an anti-inflammatory medicine, so it helps to open up whatever existing space is in that area. It's not going to fix and decompress the area, but it will help optimize the space that's available there. So that's kind of the simple solution. But now if epidural steroid injections don't seem to last for about 3 months, then we start looking at more advanced procedures. There's a procedure called minimally invasive lumbar decompression, and what we do for that is decompress the spine from the back. So in the back part of your spine here, there's a ligament here called ligamentum flavum, and that can cause pressure from the back part of your spine. You can have swelling in that ligament as one of the 3 things that causes stenosis. So what we do with very minimally invasive technique where the incision is the size of like a pencil eraser, and we stick basically a trocar or a cannula the size of a pencil into the area in the spine here, and I can decompress and pull out part of that ligament, opening up the space from the back. It takes only about 20 minutes, 30 minutes to do. It's not a big surgery. Recovery time is that day, and the next day you can resume all your regular activities. But the studies have been fantastic for this procedure for people that have moderate to severe stenosis of the spine. There's been evidence supporting significant increases in walking tolerance and standing tolerance, as well as significant improvement in pain lasting greater than like 5 years now. So the studies have been going on for quite some time, but they've all been showing very good results. The other higher advanced procedure here for spine is something called a spinal cord stimulator. So this is just a model, but it's a device that has electrical leads at the tip of a kind of a catheter here, and we place it, and this isn't not where we place the stimulators, but it's just a model. We place these electrodes into the epidural space, so just like if you were having an epidural injection, we're doing the same thing. Instead of putting steroid in there, we're sliding some wires in there. We slide the wires so they basically stimulate the back part of the spinal cord where the pain fibers run. And so if you're having back pain or even leg pain, or you have had surgery before and you still continue to have pain, you're a candidate for it. So here in the States, the FDA has approved something called failed back surgery syndrome or post-laminectomy syndrome, which is the same thing. Basically, anyone who's had spine surgery that continues to have back pain or leg pain qualifies for that diagnosis as long as everything else has been ruled out as to why they're having that pain. So if you're having that pain after surgery, you could be a candidate for this procedure. There's something called complex regional pain syndrome, which is another diagnosis that we can use stimulators for, and diabetic neuropathy. So those three are the main ones for the States, but if you go elsewhere in the world, people are using it for peripheral vascular disease. We're using it for even chest pain and angina. But this stimulator device is being used for so many new things because we're just learning all the different aspects of treatment for pain by using nerves and stimulation with electricity. So anyway, this is something that we put into your epidural space. We leave it in there, and you have a 5 to 7 day trial. So you don't have any incisions. You get the leads placed, you go home for 7 days, and you see whether or not it helps your pain. If it does, then we put the little battery in it. And so the battery is about this size. It's a pacemaker battery. And we just put it in the top part of your butt, or by kind of like where the love handles are. And we just put a little incision there, slide this little battery, slide it in the pocket. And the only other incision you get is, instead of these wires sticking outside of your skin for the trial period, we just bury the wires underneath the skin and anchor it to the tissue. So it's a really minimally invasive procedure. Recovery, again, is very minimal. So it's a really simple procedure. Both of those last two that I mentioned were really simple procedures, and they're 4 kind of higher level options that if everything isn't working or whatever, we still have solutions, towards the more advanced spectrum of interventions.
And all of those things, from some of the simpler solutions to some of the more advanced options, are all available here in Edgerton.
Yes, there are. And that's kind of a really good, strong point, because, you think of community hospitals, or you think of smaller towns as maybe not having all the facilities and all the best technology that's out there, but we really do. This hospital has put a lot of emphasis on trying to become as top-notch as their academic centers are. And I trained at Cornell, trained at Northwestern, and we're doing the same things that we would be doing there. And I know my colleagues that are there right now, we talk about these things, and we're like, yeah, it's great that we're able to branch and start putting the same kind of techniques that are available, even in smaller rural towns.